Assistant Professor of Medicine and Associate Director of the Breast Medical Oncology Program at the University of Chicago. Dr. Nanda.
So I'll be presenting the results of this clinical trial later today. Ooh, whoops. Sorry, I'm knocking off the laptop here. This is a phase 1b clinical trial of pembrolizumab in patients with advanced triple-negative breast cancer. It's okay. I have no disclosures. PD-1 is expressed primarily in activated T cells, and binding of PD-1 to its ligands, PD-L1 and PD-L2, impairs T cell function. PD-L1 is expressed primarily on tumor cells and macrophages, and tumors can use the PD-1 pathway to evade immune surveillance. Pembrolizumab is a humanized anti-PD-1 antibody, which binds with very high affinity to its PD-1 receptor. It blocks both ligand binding of PD-L1 and PD-L2. And pharmacokinetic studies support dosing of this agent every 2 to every 3 weeks. Pembrolizumab has demonstrated clinical activity in a variety of different tumor types, and just earlier this year was approved in the United States for the treatment of advanced metastatic melanoma. In the triple-negative breast cancer cohort of this study, patients with ER, PR, and HER2-negative breast cancer who had PD-L1 positive tumors were enrolled. Patients were not allowed to be on systemic steroid therapy, could not have a history of autoimmune disorders, and could have no untreated active brain metastases. Of note, approximately 60% of patients, the triple-negative patients who screened for this study, were found to have PD-L1 positive tumors. Those patients enrolled in this study received pembrolizumab at 10 milligrams per kilogram intravenously every 2 weeks. Response assessments were performed every 8 weeks, and patients were allowed to continue on study as long as they were benefiting and not having unacceptable toxicity. Of the 32 patients who participated in this study, all were female and had a mean age of 52 years. 1 in 5 was African American, and 4 of the 32 patients had a history of treated brain metastases. This patient population was relatively heavily pretreated, with almost 50% of the patients participating in this study receiving 3 or more lines of therapy in the advanced cancer setting. Also, about 90% of patients who participated in this study had received therapy in the early stage setting and had received either neoadjuvant or adjuvant chemotherapy. The majority of patients had received prior taxanes, anthracyclines, capecitabine, and platinum-based therapy, and 1 in 5 had received prior eribulin. Treatment-related adverse events occurred in approximately 56% of patients who participated in this clinical trial. The vast majority were low-grade toxicities or low-grade side effects, the most common being arthralgias, myalgias, fatigue, and nausea. Adverse events of a potentially immune-mediated nature included 3 episodes of pruritus, 1 case of grade 3 hepatitis, which was not believed to be therapy-related by the treating investigator, and 1 episode of grade 2 hypothyroidism. 4 patients who participated in this study experienced a grade 3 adverse event. These included anemia, headaches, aseptic meningitis, and pyrexia. 1 patient also experienced a grade 4 toxicity of decreased blood fibrinogen levels. This patient also went on to experience disseminated intravascular coagulation and ultimately died. Of the 32 patients who participated in this clinical trial, 27 were found to have evaluable disease based on central review. Of these 27 patients, 18.5% had a response to therapy. 1 patient had a complete response, and 4 patients had partial responses. Of note, 3 patients came off early for clinical progression and did not receive their post-baseline imaging assessment. Of the 27 evaluable patients, 90% had previously had neoadjuvant or adjuvant chemotherapy, and 4 of the 5 responders had received 3 or more lines of chemotherapy in the advanced disease setting. Of the 5 responders, all had previously been exposed to taxane and capecitabine-based therapies. 4 of the 5 had received anthracyclines, 3 platinum-based therapies, and 1 eribulin. Of the patients who had a post-treatment imaging assessment, 30% of patients had a reduction in their tumor burden. At the time of analysis, 3 of the 5 responders remained on therapy, and these patients were on therapy for 48 weeks or longer. 2 of the patients who had discontinued by the time of the analysis had received therapy for 40 weeks, and this speaks to the durability of the responses to therapy. At a median follow-up of almost 10 months, 3 patients remained on therapy, and the median duration of response was not yet reached. The median time to response was 18 weeks. The median progression-free survival for the patients participating in this study was just under 2 months, and the progression-free survival rate at 6 months was 23%. So in summary, pembrolizumab showed an acceptable safety and tolerability profile in heavily pretreated PD-L1 positive advanced triple-negative breast cancer patients. While 56% of patients did experience a therapy-related adverse event, the vast majority of these toxicities were easily managed, well tolerated, and did not require treatment discontinuation. The responses were quite durable, with 3 of the 5 responders remaining on therapy for greater than or equal to 11 months. And the acceptable safety and tolerability profile, coupled with the promising anti-tumor activity, supports the further development of pembrolizumab in patients with advanced triple-negative disease. A phase 2 study in patients with advanced triple-negative breast cancer is planned to begin enrollment in the first half of 2015. Thank you.
Excellent. Thank you so much. That was a great presentation. I think everyone continues to be quite excited about immunotherapy and breast cancer, and what this shows is what we've seen in several other studies and other tumor types, that a small portion may respond, but for those that do, there tends to be some long-term responders and durability that we don't see with often other therapies. So, Dr. Nanda, how important do you feel that being PDL positive going into these trials are for the future trial designs?
I mean, this study only enrolled patients who were PD-L1 positive, and a very liberal definition was used. Just 1% of PD-L1 positivity, either in the tumor or stroma, enabled patients to go on this study. I think it's unknown what the response would be in PD-L1 negative tumors, but I think it's certainly worth exploring.